Usually, the elbow joint has got attachments on tendons on both the inside of the elbow joint and on the outside of the elbow joint. Tennis elbow is a condition which mainly affects the attachments of the tendons on the outer aspect of the elbow joint, which are the extensor tendons of the elbow. So that is how it is different from golfer's elbow. And usually patients do get confused at times with these two different conditions, but they are very different from each other, although the pathology which is encountered is pretty much similar in both these conditions. Tennis elbow tends to be more common than the golfer's elbow. It is approximately 5 times more common than that. And it mainly affects the common extensor region, which is mainly around the outer aspect of the elbow. Although as the name goes, tennis elbow, it is not mandatory that it is only seen in tennis players. It can be seen with anybody, especially in the 4th to 6th decade of life. And usually presents itself initially with pain and discomfort, which can sometimes progress and impact the normal day-to-day life of the patients. It's mainly when it is on the inside of the elbow, this tendinopathy, that it is called as a golfer's elbow. And that's how tennis elbow differs from golfer's elbow. The golfer's elbow sometimes can be associated with more pins and needles in the ring and the little finger, as sometimes there can be an ulnar nerve involvement along with the tendinopathy, which is encountered in these conditions. These can be quite disabling, tennis elbow, and most of the both golfer's elbow as well, because it can impact the quality of life in terms of doing simple things in our day-to-day life becomes a bit of a chore. And that's sort of what brings this problem in terms of the patients presenting to see their doctors for getting it treated. So with the golfer's elbow, the pain which the patients usually encounter is on the inside of the elbow. Whereas when you get a tennis elbow, the pain is mainly on the outside of the elbow. And that is the big difference which we see in these two conditions. Although the pattern of pain can be quite similar, although it is usually seen that the pain which you get with the golfer's elbow is mainly with the flexion of the wrist, because that puts more pressure on the flexor group of muscle along with the pronator group of muscles. Whereas with the tennis elbow, the pain comes more on extension of the wrist, because it's the common extensor region with which the problem is mainly associated. So usually it is the common day-to-day things which will bring on the pain, especially with tennis elbow. The patients usually will say that the first thing when they wake up in the morning, sometimes they have more stiffness in the elbow, and as the day progresses, that stiffness usually gets better. But it's the first movement of pulling the duvet as they get out of the bed can be extremely painful. And then sometimes even holding a cup of coffee in their hands or picking up the kettle will also bring on the pain. And a lot of time there can be an overlap of these tendons as they're moving quite synergistically with each other in movements of the elbow. So sometimes the pain, it's mainly the localization of the pain, the way it sort of presents itself, that with the tennis elbow, the pain, as I said before, would be more on the outer aspect of the elbow, whereas with the golfers, it'll be more on the inner side of the elbow. Tennis elbow is rarely associated with nerve symptoms in terms of pins and needles, whereas with the golfer's elbow, because of its very close proximity of the tendons to the ulnar nerve, which is the funny bone of the elbow, that sometimes the patients can have overlapping symptoms and can present with pins and needles in their hand as well. So that can be sometimes slightly more different in terms of its presentation, but usually it is the dull ache and the sharp pain which is brought on the dull ache at times, which is the most common presenting feature. Usually the patients in the first few weeks would tend to treat it themselves, and by the time they usually come to see me, they usually have had the symptoms for a period of time, and it usually has impacted their quality of life. And that's usually how it normally presents itself. We tend to see tennis elbow more commonly than the golfer's elbow, although this is pretty much what I see in my practice, but I think a lot of reasons for that is the natural anatomy around the elbow is such that the tendon which is mainly responsible for tennis elbow is the extensor carpi radialis brevis tendon, which is responsible for the tennis elbow in approximately 90% of the patients. And this tendon is a small tendon which is stuck between the bone on the inner side, and there's another big tendon on the outer side called the east extensor carpi radialis longus. And because it's kind of stuck between a rock and a hard place, essentially, that it gets squashed, and that produces this kind of micro tears inside the tendon, which, along with increased vascularity and fibroblastic reaction, produces the picture of a tennis elbow. And I think it's because of the natural structure of the tendon that it tends itself it lends itself to producing a tennis elbow more than the golfer's elbow, because the golfer's elbow is because of a different set of tendons. And I think the structural nature, as it differs between the two, it seems that the tennis elbow tendons, being in a much more vulnerable position, it's possible that the tennis elbow is more common than what we see with the golfer's elbow. But then again, with the tennis elbow, the symptoms tend to be more tendon related, whereas with the golfer's elbow, sometimes there can be an overlap of nerve symptoms because of a close proximity of the nerve to the tendon itself. So with the tennis elbow, the pain actually seems to be one of the main presenting problems for most of these patients. And usually it is in the first few weeks of its presentation when essentially the patients do present themselves either to see the general practitioner or subsequently would see the specialist if the pain continues to persist. Some of the patients do complain of stiffness in the joint, in the elbow joint as well. But usually it is the pain and then essentially the disability which is associated with the pain itself, that they are unable to carry on with their activities of daily living, which again brings them, which kind of results in them seeking medical help. Yes, patients can present with a combination of both the tennis elbow as well as a golfer's elbow. And what is usually seen is that sometimes it can be more occupational in nature as well because of the repetitive movements or the type of job which they are doing. The percentage is approximately 20% in various studies where it has been seen that the patient can present with both the tennis elbow and the golfer's elbow at the same time. It can be possible that many of these patients can have shoulder problems, and a lot of that is because of the kinetic chain of the upper limb. Because if there is pain in the elbow joint, sometimes the upper limb will try to compensate in terms of the movements which these patients would be doing to lift things and doing the basic things. And that in itself can put more pressure on the shoulder and predispose these patients to get problems inside the shoulder. So the answer to that is yes, it is possible, and it usually is because of the compensatory movements which the patients are doing because of the pain in the elbow that it can predispose them to get problems with their shoulder. So there has been a lot of research with both the tendinopathies around the elbow, mainly the tennis elbow as well as the golfer's elbow, and a lot of research has shown that the pathology which we encounter is not that of inflammation. If anything, it's the micro tearing of the tendons which is producing a vascular reaction, a fibroblastic reaction, which is driving this the pathology in this condition. So traditionally, people have used lots of steroid injections, but I think there has now been a shift in that because research has shown, especially with some extensive randomized controlled trials, that steroid injections can actually cause more long-term problems because the studies have shown that the patients at the end of 1 year who had steroid injections and those who had no steroid injections, just physiotherapy, actually the patient in the arm which just had physiotherapy actually did better. And we also understand from the use of steroids is the collateral damage which steroids can do to the tendons which have already been weakened. And I think that has resulted in a lot of now change towards use of more biological treatments like platelet-rich plasma, and that's something which I do in my practice. And what it has shown that with the use of platelet-rich plasma, it has got lots of growth factors associated with it, and many of them in the form of transforming growth factor beta has shown to produce better healing response in terms of production of collagen. And this has shown to have better outcomes in the longer term rather than steroid injections. Now, this area of research is being very actively looked into, and there are studies which are coming through and are showing more promising results than the use of steroid injections. A lot of electron microscopic studies have also looked at the tendon structures, and it has shown that it is the pattern of laying down of collagen which is responsible for a lot of these conditions. And I think this, along with these new modalities of treatment, probably might be the way forward in treatment of tennis elbow, and more so with these patients doing better with non-operative treatment. Very rarely when the patient do not respond to non-operative treatment in the form of physiotherapy or the use of platelet-rich plasma injections, and that I would consider doing a surgical intervention.